we have Mr. George Savvides, who is here. He's going to refocus and reframe some of our discussion from this morning, and particularly give us some insight from funders and possibly a little bit from private medical insurance. Sir George has over 25 years of experience as a CEO of several Australian healthcare companies. He's an industrial engineer and has an MBA. He recently retired as CEO of Medibank Private, following 14 years at the helm of Australia's largest health fund. He has also been the CEO of Sigma Pharmaceuticals, and today he's chairman of World Vision Australia, chairman of the King's Group, director of Ryman Healthcare, and a partner of the consulting firm Sodia. And he's a strong advocate for health system reform. So thank you, George.
Well, good afternoon, everyone, and looking forward to sharing a few thoughts around the impact that the role of registries can have on health system design and performance. So I'll skip through the deck quickly and try to make the case for that you don't undervalue the financial impact you make on the system and the ability to persuade better design. Part of the importance of this conversation is the fact that we're in a sector that, unlike many others in the Australian economy, is showing no limits of growth. Very strong healthcare demand, patient complexity continuing to grow, which means more work. The healthcare professional standards remain high, and our education of healthcare professionals is a strong area of capability as a nation. And our economy is capable of maintaining a high standard as long as we manage system performance. Beware of endless demand without discernment. We're travelling well at the moment in terms of how Australians perceive their health system. It's relatively high in its rating, even on the blue columns, which is the low-income segment of our population, continuing to rate it high, as well as those in higher incomes relative to other markets in the world. But chronic disease and the prevalence of complexity in chronic disease, more than one disease contributor, continues to grow, and it will grow at an accelerated rate as the baby boomer population moves through. The two arrows to the right, I think, are the leadership challenge. So this is, where do you take the research when you've found a better way? You've got to change behaviour and leadership. And I've labelled it there adaptive leadership, where we say we learn from our research and then we say what are the better pathways, where is the waste, where should the emphasis lie for better treatment outcomes? Or do we revert to type, just go for silos, stay in your bunker, subspecialise, don't worry about the other guys, and hope the patient works out how to navigate and get an outcome? The default to silo is natural. Most health systems in the world have plenty of individualism in healthcare in terms of specialties. The hard work is integration and coordination. As a nation, as we move to 2050, the cost of healthcare exceeds the income that the nation can set aside to fund it if we do nothing on design. And I'm an optimist, as I come from the world of funders with health fund in Medibank, but also if you're funding Medicare, you'd have the same concerns. How do we change the direction of the cost curve so that our health system grows at the rate of our economy, so we don't end up with an accumulation effect where we want to do great things for our people, but we don't have the dollars because the system is inefficient? Is it inefficient? Do we have any evidence of that? Well, it's certainly out of balance. Hospital admissions in the last 10 years have grown 41% per person in terms of cover and admission rate ratios. So that consumption of healthcare indicates that there is a default to acute high cost. So what's happening with our primary care environment? Other ways of segmenting healthcare labelling in terms of key areas of treatment. You see the green bar dominates, and that's the acute system, dominating the dollars, dominating the resources, and creating its own inefficiency and cycle. That's how many of the funders see it. There's absolutely a role for acute care, but how do we balance that role with an integrated primary care system? That's the system design challenge. So new technology produces great outcomes, and there's lots of it coming through. How it's applied and the percentage of its application is really the clever side of application, and sometimes we get that wrong. Chronic disease, we know, is growing in prevalence, and ageing definitely. So we have those three factors that multiply or accentuate year-on-year growth in healthcare dollars. So how do you bend the cost curve? Well, in my engineering days, we look for waste. We start with a production system that might have 15% leakage, and we look for the sources of leakage or waste, whether it's inventory stalling or inappropriate machine dynamics or tolerances are in error that produce an out-of-tolerance outcome in the final product. And by honing that and improving that and having a continuous improvement cycle, you reduce waste and products become more affordable, more efficient, more competitive. Can you apply the same logic in the health system? Well, certainly we do a lot of things in the healthcare system that produce no healthcare value, whether it's through default settings, where diagnostic tests are taken but never read, where patient data does exist but it's not accessible at the time of need for appropriate decision making. There are lots of issues in the system, opportunities in the system to save dollars. As a health fund, when I was at Medibank, we would spend $5 billion a year to cover the healthcare costs of 4 million Australians. In the data analytics work that we undertook there, supported by some data from registries as well, we were able to identify more than 10% of system waste in the claims data that we purchased, in the claims that we paid for. We want to pay 100% of claims that produce good value, but not pay for things that produce no value. In the Australian health system, system waste is twice the size of healthcare CPI. So the annual cost increases of maintaining the Australian health system, the inflationary costs, are dwarfed by the wasted costs in the total system. If we can save some of the wasteful costs, we can bend the cost curve and still do all the good work that we need to do and afford it on a sustainable basis. Yeah, it's easy to say, George, but how do you do it? Well, we do have an unusually complicated system. I just spent a week in New Zealand. Part of it was a nice holiday in Queenstown, and I just get so jealous when I see a system so well integrated, or certainly better than ours, when it comes to primary and acute care. So we have public and private discontinuities, where the funding gaps occur and people are exposed to out-of-pockets. We have federal and state divide, where one wants the other to pay for something that they don't want to pay for, and there's a dispute or an overlap or an underlap. And we also have discontinuities between acute and primary care. The hand pass is not good, or the revisitation rate is high because we don't do it well in primary care. So we could go back to the early slides and say, no, it's okay. We've got plenty of demand. We've got a healthy and wealthy economy, and we should be fine, George. Don't get too worried. But the complacency card is actually the enemy of great. And when you as researchers understand the system performance and see better ways and want to see your data converted into better practices, then we know we should actually reach for great and start to redesign some parts of our health system that produce little value, or in some cases negative value. Change is part of the paradigm that we're in. Registries bring fact and insight into our health system performance, offering design input for the best pathways and team-based interventions. We need the output of your registry data to redesign and produce a high-performing health system. The dollars and the impact that you have in that data are very, very significant, and I'll show you some of those in a minute. Funders are struggling with this assignment as well. You should find friends in the funding environment. Some of the collaborative work that Medibank undertook with some of the registries here in Victoria produced greater insight into the waste area of their claims that they were able to harvest for greater cost efficiencies. I coined the phrase, identity is the mirror of purpose. When registries provide insight on clinical performance, they provide a picture of a desired future for optimal care. This evidence-based image of optimal pathways will inform the necessary health system design changes and transformations we need to undertake. We can trust the data. We have a lot of opinions in healthcare, but the data is powerful. It will inform the investment in the right kind of integrated primary care we undertake and the way that segues into acute care when necessary. Registries inform optimal design and ultimately identity of our health system, potentially a great one. So your work is very, very important. It's the key to long-term sustainability and affordability of a great health system. I drew this bucket up on the back of an envelope a few years ago, and the graphic people made it more intelligible. But we have a $155 billion health system. We pour that money in every year. There's several taps at the top of the bucket. Federal government, state government, patients in out-of-pockets, private health funders, other insurers like traffic accident, etc. It's a lot of money, $155 billion allocated across all of those discontinuities that I talked about. Discontinuities leak. They create gaps between public and private, primary care that's not integrated, and also in terms of the way capital expenditure is allocated. We identified 5 key areas of waste in the system, which total to twice healthcare CPI per year. So let's talk about it in terms of, say, 10 to 15% waste out of the $155 billion a year. The categories are high care needs patients. 3% of the Australian population consume 33% of healthcare dollars. But we treat them like the 97% who just need a single consultation, because we play the volume card instead of the impact card. There is identified already in the MBS review a whole lot of unnecessary practice that produces no clinical outcomes, but we still pay for it because there is an MBS item number next to it. There is unwarranted variation in the claims data of a health fund. You'll find hips and knees adjusted for age of the patient, where the variation in total cost of treatment is up to 50% across Australia in 1 year. Why would a hip surgery be out of whack by 50% in any one jurisdiction when you neutralise the age effect? Yet we pay at the top of the bell curve. In complications, yes, complications do happen. Incidents and failure in some cases, or medication complication occurs. But pathways that avoid that or reduce the likelihood through continuous improvement can reduce the complication waste area and the lack of timely information at the point of care and decision making. All of these 5 areas contribute to more than 10% of the $155 billion of system waste. Your registry work can impact $15 billion of healthcare system performance a year. You should not be struggling to get the money if we understood the impact that you could have on this system and the leakages in the bucket. So the summary of that health system underperformance are areas that I would hope your data and your work link to directly. So whatever you're working on related to unwarranted variation, or identify better or worse care pathways and then try to design out the underperforming ones. Or inappropriate treatment, identify it and let's take it out of our system design. You just go down the list. If you can build the bridge of registry insight into funder identified weaknesses in payment, you'll find a lot of friends. Going back to the primary care concerns that we have. In the Medibank world, we had 3% of our members, we knew them by name, who consumed 33% of health system costs in the claims $5 billion data that we paid out every year. The idea here was to actually spend more money on the 3%, to coordinate their primary care more effectively, to give them the right kind of support across the various treatment areas that they needed, given that they were high-frequency system users. The reason that was a clever thing to do was it would lower the unnecessary admission into acute care. Spend $2,000 or $3,000 a year in coordination, hand-holding and support, and avoid a $40,000 or $50,000 acute admission that would happen by default if that coordinated care wasn't there. I need your data. to prove that point time and time again so we can redesign pathway. Some health funds have had some great success. In the recent data that Medibank released in their last couple of years of results, they've managed to pay 100% of their claims in the underwriting benefit, but only grow their care costs by 0% in ancillary and 1.4% in acute. How did they do that? They found some of the waste. How did they do that? They had a very large data and analytics team, and they accessed registries to get better insight. The more we do that, the more we can rebalance this system imbalance in the Australian environment, where we overspend on acute because it's a default setting, and we underspend on intentional integrated primary care. Too many times we default into the silo mindset of primary care, where we do things in separate specialisations, and we end up undermining the team care opportunity. I have a friend, Dr. David Kerr, who's the chairman of Ryman Healthcare in New Zealand, and David works in the Canterbury district, influences healthcare design there as a researcher as well. And they recently put physios, GPs and orthopaedic surgeons together in a assessment team to directly engage waiting lists in public care, and also to intervene in the treatment of individuals with serious injuries in primary care to work out how best to deal with treatment pathways. And they ended up with a significant saving to healthcare system budget, but reduced the waiting lists dramatically by getting people the care they absolutely needed. The point of this particular research was, across different care providers, they created a team, and the team embraced the patient. When people are enrolled in coordinated care programs, they produce different cost utilisation in acute care. Those in programs are in the green bars, and those who are in pre-enrolment are in blue, and you can see the dramatic effect of coordinating people in primary care programs and the effect that has in reducing unnecessary acute care. In Sweden, I think Sweden's been mentioned today, so I'm not sure if I'm on solid ground, but in the 60s, they provided services with coordinated networks. Resources were pooled. 80% of the Swedish population are covered in an integrated care program, so that those discontinuities that I talked about in our system were overcome through an integrated program enrolment process. And the number of hospital beds in Sweden actually reduced by 45% through the 90s, but they heavily invested in primary care through the integrated programs. Significant change in the balancing of their healthcare system, and therefore a significant move to sustainability. Without integration, we have 24 million Australians visiting around 70,000 providers. And it's call who you like. Don't worry about your history. And if you have a multi-diagnostic environment in terms of primary care in terms of chronic disease complexity, just keep going to whoever you need to go to, but there will be no history or coordination. Without integration, we will not be able to afford the sustainability of an excellent healthcare system. And without integration and coordination, we won't be able to bend the cost curve. How do you bend the cost curve? You have insight. Where do you get insight? From people who develop the hard work of registries and the analysis of registry output. And the impact? Well, better system design and integration of services around the patient, reduce heart failure by 25%, amputation by 34%, and stroke by 45%. We're much more informed about our patients, they're in the right pathways, and as a result of that, they get better healthcare outcomes at a more affordable funding equation for the funder, whether that's Medicare or Bupa or Medibank in the private side. So I'm going to stop there and invite maybe one or two questions, if that's possible. One question. Which brave soul would like to ask a question? I get off the hook, do I? Fantastic. Have a great afternoon. Enjoy the rest of the conference.